That belly fat you've been trying to lose your entire adult life? Your face has quietly been waiting for it. I know how that sounds. But hear me out. There's something happening on your stomach, your thighs, your flanks, that the rest of your face could actually use a lot better than your belly ever did. It's your own tissue, which means that your body doesn't fight it the way it fights everything else we put in the face. And that one fact is why fat behaves completely differently than anything like filler or anything else in cosmetic medicine. Unfortunately, it's also one of the few cosmetic decisions that you have a hard time taking back. We're gonna get into that. I'm gonna cover all of this, what fat transfer actually is, where it works, how it might not work, and by the end of this video, a clear way to figure out whether you're a good candidate. And stick around for the bonus tip at the end. I'll give you one specific question to ask any surgeon you're considering, and their answer will tell you almost everything you need to know about whether they're the right person for this. I'm Dr. Kian Eftekhari, oculofacial plastic surgeon at the Eyelid Center of Utah. My practice is exclusively the eyelid and periorbital area. I perform fat transfer as part of that practice, usually in combination with eyelid or eyebrow surgery. And I have strong opinions about when it's the right tool and when it isn't. You're gonna hear both. Let's start with this. What the heck is fat transfer anyway? So it goes by a few names. Fat transfer, fat grafting, even facial lipostructure. The surgeon who popularized this is a guy named Dr. Sidney Coleman in New York City. The procedure begins at a donor site, usually the inner thighs or the abdomen or the flanks, through a small puncture. I'm talking tiny. A thin cannula, 2.4 millimeters in width, it's used to remove fat using a gentle manual suction technique. Gentle matters here. The goal is to pull the fat cells out intact, not damage them. Once the fat gets removed, it gets processed. That usually means letting it separate into different layers. Some docs use something called a centrifuge, but that's kind of personal preference. Either way, the goal is to separate the viable fat cells from the anesthesia fluid, the oil layer, and any cellular debris that you don't want. Often what I do is I resize the fat using a transfer device as well. What's left is a concentrated layer of living fat cells. Some people call these stem cells. Those cells then get loaded into small syringes and injected into the face through even tinier cannulas. The one I use is less than a millimeter in width. The whole harvest to injection sequence takes about 30 minutes depending on how many areas we're treating. Now here's why fat transfer is different from everything else. Because these are your own cells, not a foreign material, not a synthetic gel like filler, your body doesn't try to reject them. What happens instead is that those transferred fat cells try to integrate into the surrounding tissue, and a lot of them survive. And when they integrate, they stay around, not for 6 months, not for a year. We're talking many years. That's the property that no filler can replicate. Think of it this way. Filler is like placing, let's say, like a decorative stone on top of your garden soil. It's nice and shiny right away, but it's a foreign substance and it's kind of just sitting on the surface. It doesn't have roots. Eventually it loses its shape, it breaks down, it needs to be dissolved or replaced. Fat transfer is like planting a flower and bringing the roots with it. It takes longer. There is some uncertainty about whether it'll fully survive, but if it does, it establishes itself. It kind of becomes part of the landscape. It has a living character to it. It's alive. It belongs there. The takeaway is, filler kind of decorates the surface. Fat transfer becomes part of your tissues. But here's the thing. Fat doesn't work the same way in every part of the face. There are zones where it's spectacular and zones where I wouldn't even attempt it. Let me show you the difference. The number one zone where fat transfer earns its reputation is the under eye area, the tear trough, particularly in patients who are already having a lower eyelid blepharoplasty procedure. Quick analogy to think about this procedure, most under eye bags are there because there's bulging fat above the cheekbone. Think about that like a speed bump on the road, with hollowness and not enough fat just underneath it. Think about that like a dip in the road. Those two things together accentuate the appearance of the bag. The best way to fix this is to shave down the speed bump with a lower eyelid surgery and then fill in the dip in the road using somebody's own fat. And I often do both things at once. We're removing what shouldn't be there and replacing it with what should. The recovery overlap makes the timing really efficient. The second area to target for fat transfer is the temples. Temple hollowing is one of the earliest signs of facial volume loss and one of the most aging. And it's an area where filler can look okay-ish, but sometimes a little unnatural or kind of fluid-like. Fat integrates here beautifully. The third area is the upper cheek along the bone here. And I like to volumize this area and sometimes also the brow area to give the outer brow a little bit more projection. Now, here's the question. Why is fat better than filler? Well, a few reasons. Filler under the eye carries some risks. One of them is called the Tyndall effect, which is that bluish discoloration from filler sitting too close to the surface. That doesn't happen with fat. The need to repeat it every year that you have with filler, not the case with fat. Having it sit there and sort of lose shape over time and sit in your face like mush, like filler? Nope, not with fat. Now, I want to be direct here. Fat transfer around the eyes requires a high level of technical precision. This is not a forgiving area. Too much volume in the wrong tissue plane creates a puffiness that's a lot harder to reverse than filler. Which brings me to the part of the conversation most surgeons selling you on fat transfer might not say out loud. Now, here's the thing. You can dissolve filler. There's an enzyme called hyaluronidase that takes it out. You really can't dissolve fat. Once it's there and it survives, it's there. And that one fact changes the whole conversation about whether this is the right procedure for you. Everything I just told you about the longevity, the integration, the natural glow, all of it does have a flip side. Permanence cuts both ways. When fat goes in and behaves the way you want, it's the best volume restoration we have. When it doesn't, you might have to have another procedure to remove some of it. So the argument for fat transfer in this area is not that it's easier or lower risk, it's that in the right hands, in the right patient, the quality and the longevity of the results is in a totally different category from filler. But you have to know what you're signing up for. So let's talk about the rest of the trade-offs. The first one is about survival. On average, somewhere between 40 to 70% of the fat that's transferred survives long term. Now that's a wide range and it's really hard to study. It's wide for real reasons. Surgical technique, the specific site you're putting it in, your circulation, whether you smoke, and some underlying biology that nobody really fully controls. Because of this, surgeons kind of have to account for that unpredictability. Most patients don't really see their final result until even 3 or sometimes 6 months out. And if nobody told you that going in, the first month is going to be super swollen. The second trade-off is about healing. There are 2 wound sites with fat transfer. The donor area, wherever the fat was taken, will have some bruising, soreness, and swelling on its own. It's not dramatic, but it's annoying. The face will have swelling that can be asymmetric, which is a little disorienting. One side may look more swollen than the other for a few weeks. That usually evens out, but it does require some patience. This is not a procedure that you do on a Friday and you try to return to work looking perfect on a Monday. Patients who come in expecting a filler equivalent experience are going to be surprised. I'd rather give you the accurate version of this up front than have you discover this the hard way. The third trade-off is that revisions are harder than filler. If too much fat survives, and that does happen maybe 1% of the time, there's really no enzyme to dissolve this. The options for addressing this include waiting a little bit for natural resorption or a revisional procedure. This isn't common, but it is real, and you deserve to know that going in. The flip side of this is underfill of fat, where a little bit more fat resorbs than we expected, and the patient maybe needs to have a touch-up. That's more manageable. A second small session of fat transfer can address it, but the revision calculus for fat grafting is different from filler, and anyone who tells you otherwise is kind of glossing over something really important. The takeaway? Fat transfer trades reversibility for longevity. If you understand that trade going in, the procedure makes sense. If you don't, this is the wrong procedure for you. Let me tell you about the patients I steer away from fat transfer. Not because fat transfer is bad for them, but because it's the wrong tool for their situation. Heavy smokers aren't great because smoking impairs circulation, which can dramatically reduce the survival rates. The second one is patients who are super lean with minimal fat to give. That can mean that I can't fill every area you want because there isn't enough high quality fat to remove. This is especially true in the age of Ozempic. So how do you know if you're a good candidate? Here's your self-assessment framework. You're a strong candidate for periorbital or facial fat transfer if, number 1, you have genuine volume loss, not skin laxity. So in our analogy of the lower eyelid with the speed bump and the dip, this is referring to the dip. Most people do have some volume loss along the cheekbone, meaning the cheekbone doesn't have that youthful fullness that you once had. The number 2 reason that you're a good candidate is if your weight is relatively stable. Now this one surprises people, so let me explain it. Once fat is transferred to your face, it behaves like body fat because that's what it is. If you gain a lot of weight after fat transfer, you may gain a small percentage of fat in your face too. Conversely, if you lose weight, your face may lose some fat with it. It still remembers that it used to be body fat. Significant weight fluctuation after the procedure can alter the result in ways that are a little bit hard to predict. Number 3 reason that you could be a good candidate is if you have realistic expectations about that 3-month timeline before you see your final result. Number 4, and this is the one that makes fat transfer the most efficient, is if you're already planning on having another procedure. Blepharoplasty or eyelid lift, lower eyelid work, brow or forehead work, something that requires operating room time. Adding fat transfer in that setting means 1 recovery, not 2. That's when this procedure makes the most logistical sense. So the takeaway is real volume loss or stable weight, a realistic timeline, and ideally a plan for some kind of surgery. If you check all those 4 boxes, this is definitely a procedure worth a conversation with a surgeon who knows what they're doing. So here's the question I promised at the beginning. Before you choose a surgeon for any kind of lower eyelid work, ask them this: do you offer fat transfer in combination with lower eyelid blepharoplasty? That's it, simple question. But the answer is very revealing. Here's why. Lower blepharoplasty and fat transfer are not the same procedure, but they address overlapping problems in the same area. Some patients need fat removed, some need fat restored, some need both. A surgeon who only does one of those things every single time for every single patient is not adapting to your anatomy. If they only offer you one option for your eyes and they say that they don't do fat transfer, then they're just kind of having a cookie cutter approach or running a protocol. And a protocol is fine if your situation fits into their protocol, but a lot of people don't. Everybody's unique. If the answer instead is a thoughtful explanation of when they would combine the two or when they wouldn't, then that's a surgeon who's thinking about your specific anatomy, not just running their usual approach. The best outcomes come from surgeons who have more than one tool and know when and how to use each one. That one question will get you there fast. So fat transfer done right, in the right patient, is one of the most natural looking and long-lasting volume solutions we have. And for the right person, it's a great option. Drop a comment and tell me where on your face you've noticed the most volume loss. Under the eyes, temples, cheeks, wherever it is. I do read them and it genuinely helps me understand what I want to cover next. If you're comparing fat transfer to filler as options for the under eye area specifically, I have a full video on tear trough filler, what it does, when it fails, and why, linked right here. Worth watching that before you make any decisions. And if you want to get an evaluation, go to eyelid.pro/book for a link to consultation. Subscribe for more videos. I'll see you in the next one.